Hello everyone, this is Dr. Piyush from Srimati Kashibai Navle Medical College, and my topic for scientific paper is A Cyst in Disguise, the Peritoneal CSF Pseudocyst Conundrum. Peritoneal CSF pseudocyst is a rare complication of ventriculoperitoneal shunting and can mimic ovarian cystic lesions on imaging, leading to diagnostic uncertainty. A 22-year-old female patient presented with lower abdominal pain and ultrasound suggested a cystic abdominopelvic lesion. Subsequent MRI and CT imaging demonstrated a well-defined uniloculated fluid collection encasing the distal tip of a ventriculoperitoneal shunt catheter, favoring a diagnosis of peritoneal CSF pseudocyst over an ovarian etiology. Key imaging clues include identification of the shunt catheter, extra-ovarian location, and simple fluid characteristics. Correlation with clinical history is critical to avoid misdiagnosis. Introduction: A peritoneal CSF pseudocyst is a rare complication of VP shunt catheter placement. The time from the last shunting procedure to the development of an abdominal pseudocyst ranges from 3 weeks to 5 years. It results from loculated accumulation of CSF within the peritoneal cavity, often secondary to infection, inflammation, or impaired absorption. The wall is composed of fibrous tissue without an epithelial lining. Debris is identified in the majority of the fluid collection. The pseudocyst can either move freely within the peritoneal cavity or adhere to the serosal surface of solid organs, the parietal peritoneum or small bowel loops. The latter would explain why some bowel loops may become engulfed within the pseudocyst, increases in size, or why the pseudocyst may be prone to torsion. Pediatric patients commonly present with symptoms of elevated intracranial pressure and abdominal pain, whereas adults predominantly present with abdominal signs only. On imaging, it typically appears as a well-defined cystic lesion and may closely mimic intra-abdominal or pelvic pathologies, particularly ovarian cystic lesions in female patients. This overlap in imaging features can lead to diagnostic confusion, especially on initial ultrasonography. Recognition of key radiological findings such as the presence of shunt catheter, extra-ovarian location, and characteristic fluid attenuation is crucial for accurate diagnosis. We present a case highlighting this diagnostic dilemma and emphasize the role of cross-sectional imaging in differentiation. The, the aims and objectives include to highlight the radiological features that differentiate peritoneal CSF pseudocyst from ovarian cystic lesions and reduce diagnostic ambiguity. Clinical profile: 22-year-old female came with complaints of pain in abdomen and abdominal distension with loss of appetite and body weight. There was no history of vomiting, altered bowel or bladder habits, PV bleeding or discharge, or fever. She had normal menstrual history with regular periods and moderate flow. She had similar complaints 6 months ago, and she is a known case of seizure disorder and tuberculosis on medication. She is an operated case of ventricular peritoneal shunting done 10 years ago in view of hydrocephalus. No other comorbidities or significant past or family history was present. Investigation: CA-125 was 213 units per ml, which was raised. USG abdomen and pelvis revealed moderate ascites with multiple echoes and septate within. Contrast-enhanced MRI pelvis showed a periphery enhancing loculated fluid collection with multiple T2 hypointense septations within, engulfing the bowel loose and a simple ovarian cyst in the right ovary. These are the sagittal T2 weighted images of pelvis showing a loculated fluid collection with T2 hypointense septations within. We can also see this collection is separate from the right ovary and there is a simple ovarian cyst in the right ovary. Axial T1-FS post-contrast images showing peripheral enhancement of this loculated fluid collection. It is also seen engulfing the bowel loops, likely due to adherence of the serosal surface of the small bowel loops. Ascitic tap of the fluid collection was done to relieve the symptoms and was sent for analysis. Fluid analysis revealed tuberculosis and the patient was started on AKT. Patient's symptoms were relieved and she continued the AKT treatment. She had similar complaints of abdominal pain and distension 6 months later. She was admitted in the hospital for one episode of seizure. Investigations at present revealed CA-125 is 9 units per ml and in the normal range. USG abdomen and pelvis revealed a large, well-defined abdominopelvic cystic lesions and the ovaries were not well visualized. MRI and CT brain confirmed the presence of VP shunt and hydrocephalus. Contrast-enhanced MRI pelvis showed a large, well-defined, peripherally enhancing T2-star hyperintense uniloculated collection in the abdomen and pelvis without any septate or solid component within. Axial T2 and CT bone window of brain showing the tip of the VP shunt in the right lateral ventricle along with hydrocephalus. This is a sagittal and axial T2 weighted images of pelvis and abdomen showing a large, well-defined, round, uniloculated, hyperintense fluid collection without any septations or solid components within, which is seen separately from the ovaries. It is also seen compressing the surrounding bowel loops. Uh, the ghosting motion artifacts is seen due to the bowel movements. Post-contrast images showed peripheral enhancement of the fluid collection, but there were no septations or solid component within. We can also see the compression of the surrounding bowel loops. Sagittal T2 coronal and axial star images of pelvis showing the PP shunt in the fluid collection. To confirm the presence of the tip of the VP shunt inside the fluid collection, USG pelvis was run, which confirmed our diagnosis of peritoneal CSF pseudocyst. For further management, the pseudocyst was excised and sent for investigation. Pseudocyst wall revealed squamous epithelial cells on microscopic examination. Fluid analysis showed clear serous fluid with few inflammatory cells infiltrate without any acid-fast bacilli or atypical malignant cells. Treatment and prognosis include excision and repositioning of the shunt tip with minimally invasive laparoscopic techniques. This technique in the setting of a non-infected pseudocyst has proven to be safe with results comparative to those of a conventional open surgical technique. If infection is present, the pseudocyst wall should be excised and the peritoneal shunt tube removed. Percutaneous drainage of the pseudocyst can be done for diagnostic. Peritoneal CSF pseudocyst is a rare complication of VP shunt. On ultrasonography, it may appear as a cystic adnexal lesion, leading to potential misinterpretation as an ovarian pathology. Identification of normal ovaries separate from the lesion, visualization of shunt tip within the collection, and simple fluid characteristics are important diagnostic clues. Therefore, peritoneal CSF pseudocyst should be considered in the differential diagnosis of cystic pelvic lesions in patients with VP shunts. Awareness of key imaging features and clinical correlation can help radiologists accurately distinguish it from ovarian cystic lesions and thereby guiding appropriate management and preventing misdiagnosis. Thank you.